so as Margarita said, I'm really interested in this question about how we can sort of use COVID-19 as a lens for understanding sort of the bigger picture in some sense about our health. And so I think there's a way we can sort of use the particular sort of homelessness and housing insecurity challenges that arose during the COVID-19 pandemic as a lens for basically looking more carefully and looking in different ways at the wider relationship between housing and health, and the way that trying to address housing could in some ways could help promote better health. So I'll get into this in a moment, and this is all part of a book project. And it's the thing that's sort of been on my mind since actually fairly early in the pandemic is sort of what's next. And I think that's a question that a lot of people have been asking since actually fairly early on. Is there's sort of both the descriptive question and the normative question of what comes next. So what comes next for travel? What comes next for the nature of work and working at a distance? And what comes next for urban design and the relationship to ruralness? All these different questions. What comes next for children? And so there's the descriptive component, there's also the normative component. So there's not just what is going to happen, but also what would we like to happen. And so I am essentially writing a book about that because I think as all the other people have been pointing out, now is the time to think about what kind of world we want to sort of rebuild after so much has essentially fallen apart in some way or another. And so, the housing crises that have been happening both in the U.S. and in England and across the U.K., those really interest me as being sort of one of those sort of like focal points for looking at what exactly happened that went wrong, what went well, how can we build something better in the wake of this. So, as you're probably well aware, pandemics are really quite a stress test for a society, or a test of its society's resiliency. And so you have all this sort of a combination of different sort of like little micro crises or sort of like subsets of crises happening at the same time. So you have hospitals filling with sick people, you have stress, caregiving, you have grief affecting even those who aren't infected. So it's not as if only people who are directly infected by a pandemic are the ones that are being harmed by it. You have economic and social systems that are disrupted by both formal policies and by individual behaviors. I can elaborate on this point, but there's an important point that was made by Nancy Krieger in an article a few years ago that it's really a conceptual mistake to assume that that we can sort of like additively see some sort of relation, additively see that, oh, well, this percent of the mitigation efforts were due to formal policies and this percent were due to individual behaviors. It doesn't really work that way. And it's unfortunately the case that individual behavior and formal policies are basically closely meshed together. And so we can't sort of separate out the, or at least certainly not easily, and in some ways it's almost sort of impossible, separate out the interplay between formal policies and individual behavior. And so I want to sort of make that point at the outset, because this isn't sort of like a critique of lockdown policies or the nature of lockdown policies. I think a lot of the debates about sort of the benefits and drawbacks of those are in some sense falling into the conceptual trap that Krieger pointed out. The way she called it was the fallacy of assuming health determinants add up to 100%. And so that sort of non-additive relationship between individual behaviors and sort of like formal structures is hard to parse. Anyway, so I just want to make that sort of point, because this isn't sort of a veiled critique or defense or something of those policies. And in this process, effective health communication just becomes absolutely essential. And so it really matters quite a bit how we talk about what we're doing and what kind of policies we're putting into place, what we're attempting to accomplish, what our goals are, what our motivations are. And so it just becomes extremely important about just sort of to communicate all of these different things. So, and that's probably relatively obvious, but I thought I would sort of repeat just in case it's not. So let's get into the issue of housing crises. So first, here's a little snapshot of homelessness in the United States. So the way both the U.S. and England try to capture the homelessness issue is, and this seems to be sort of the prevailing way of trying to do it, is basically you can set a sort of a point in time, and you can do this every single year, where you try to look at what is the state of homelessness at that single moment, because that's a methodological choice that's quite important, because you can measure homelessness in terms of what % of people have experienced homelessness over the past year, or 2 years, or 5 years, or 3 months, or whatever it might be. That will give you quite a different answer than how many people on a single day. In the U.S., we do it in January, I believe. In the UK, I believe it's in the fall. In that single day or single week, however you want to do it, how many people are experiencing it right then. And so that sort of snapshot allows you to sort of compare snapshots over time without having to sort of to measure like how many days of the past year or something like that has somebody experienced homelessness. So with that in mind, when the U.S. did its last January one, or the one for which the data is available, we had about 580,000 people experiencing homelessness, which is 0.17% of the U.S. population. And they were roughly evenly spread between people in temporary shelter and people who are entirely unsheltered, or rough sleeping, I believe is the term used in England. So by comparison to the housing security in Britain, I'm going to focus mostly on England, since that's where most of the data and some of the interventions we're going to talk about are coming from. But I realize that England, Britain, UK these are different concepts. So I'm not an entirely unaware American, but it's just a sort of matter of where the data is coming from. So in England, it seems that there are roughly 100,000 to 150,000 people experiencing homelessness at a given moment, depending on how you do the measure, or depending on which estimate you lean on. It's roughly comparable to the rate inside the United States, or a bit higher. It sort of depends on how you, again, all these sort of methodological choices about how you measure this kind of thing. The number of people actually sleeping rough in a given year is actually much lower, and so the minimum number in terms of the number of people who've actually been observed is in the order of 4,000 to 6,000, something like that. The number of observed people sleeping rough drastically fell during the Everyone In program. Are you all familiar with that? I'm not sure what's. So the Everyone In program, for those of you who might not be sort of keeping up with the news, is essentially the program to try to give at least temporary pandemic housing to everyone who is sleeping rough in England. It's during basically the first wave of lockdowns. It's quite an admirable policy insofar as in the United States we had these policies saying it's basically called stay-at-home policies, and that's quite an impossible thing if one does not have a home. And so you all figured out that that's actually something you need to address. And so eventually the Everyone In program secured this emergency housing for 33,000 people. And so there's this sort of real ambiguity about the scope of the sort of housing security issue, because 33,000 people partook in this emergency housing because they were at risk of or were sleeping rough. And so these numbers, as far as like how many people actually are experiencing homelessness in England, is really quite ambiguous, and it's highly dependent on the measures one uses. I'm just want to sort of reemphasize that. So there's so that ambiguity is sort of there in the data. It's not being unnoticed. If you take a look at if you take sort of like a broader sort of understanding of what counts as housing insecurity, or what counts as a housing crisis, then the numbers are much larger. And so if you take the approach that like shelter the NGO in England, then if you take that to be anyone who's experiencing housing that is unfit, that is unsafe. And so if your housing has extensive mold, if you aren't able to afford heating for it, if you are at risk of being of losing your housing within a short period of time, all these sort of like stressors, then it's roughly a third of England is experiencing some sort of housing crisis. And so so again, sort of depends on where you sort of set the bar as far as like how many people are experiencing this crisis. I assume everyone is sort of aware of the increasing housing costs because you're probably all feeling it in some way or another. So there are actually some striking similarities between the U.S. and England, and one of them is in sort of the scope of the detriment that homelessness brings on one's health. And so it seems to be that the experiencing homelessness drops one's life expectancy by around 30 years. It's a bit more severe in England and Wales than it is in the United States, although in both cases it is extremely, extremely bad. If you sort of think about it in sort of, it's hard to get a sense of it's hard to convey how much that is, other than just saying like roughly 3 decades of one's life. But if you, it basically pushes one back into like 100 years in terms of like human development and experiences and experiences. So it sort of puts one into sort of the mortality categories and the mortality experiences of experience roughly 100 years ago. It's that severe of a drop in life expectancy. And then, as you might imagine, there were special risks. Oh, is there a question?
There's a. Are you okay?
Yeah, no, please. Since it's a small audience, so just jump in, anybody.
Yeah.
Sorry, I hope you wouldn't mind. It's just a sort of clarification point. I suppose the obvious question when you look at the statistic is the 3-decade drop in life expectancy the result of becoming homeless, or is it because
drop
and the homelessness together the result of some other cause, like, well, frankly, obvious examples, drug addiction, or just other forms of very poor health, inability to work as a result?
Yeah, it's this is an interesting sort of it's a philosophical question. You can sort of make the same sort of thing with lots of other sort of I mean, you can call people experiencing homelessness, that's a demographic category. I mean, I've done sort of analogous work on I have a paper coming out in a few days, I think, on we can sort of make the same sort of questions about something like ethnicity or race. And so it is not as if someone's status as being African American or Black African or whatever other sort of like racial or ethnic category that's used that's at a national or state level. The people don't die younger because they are that per se. They experience that because their demographic status is associated with a variety of risks that sort of accumulate over the life course. And so some of them might be sort of in direct reaction to their experienced to their racial identity. So it could be that they are given less access to housing, for instance. So there's a lot of housing discrimination in the United States, and there seems to be there's quite a bit in England as well. People are reporting that, and so they're having a hard time securing lodging. They're having a harder time securing good rates for that lodging, so affordable rents, that sort of thing. And so, but other risks are due to things like inherited wealth or lack of inherited wealth. I'll come back to that in a moment soon, including the racial disparities and ethnic disparities. And so in some sense, it matters quite a bit, sort of like where those risks are coming from. And so what is it about homelessness that is associated with lower life expectancy? In some sense, it very deeply matters, and especially for trying to correct interventions. In another sense, it doesn't. It is the way I think it is. It's an inequity either way. And so whether it's because of sort of historical legacies that African Americans die about 5 years younger than white Americans, or whether it's due to direct experiences of discrimination, or whether it's due to the process what's called weathering, where basically perceptions of being discriminated against sort of accumulate cardiovascular risks. And so we don't know exactly how to sort of parse those out. But either way, it's an equity that Black Americans are dying that many years younger, or that people experiencing homelessness died as many years younger. So so it is an interesting question, because it's like I said, I think it's an inequity no matter where it's coming from. But the experience of sleeping rough, for instance, isn't necessarily the thing that is causing it per se. So yeah, thanks for the question, because it's an interesting one.
Sorry. There's another hopefully quick clarificatory question from them.
No, please go ahead. Yeah, I'm happy to have this be sort of like a sort of free flowing kind of thing.
Sorry for interrupting it.
It's
just a super quick question. So about this statistics again. So is experiencing homelessness independent of the time of the homelessness period, or so what is like, or is like an average of all the people that have ever experienced homelessness? This was just a clarificatory question. Sorry.
Yeah, it's these are sort of the best estimates that are available. It's actually it's rather depressing how little data there is available on this point. One of the most widely used attempts to try to do this is to basically for the jurisdictions around the world, or in the US and England or whatever, that have essentially that at the time of death, when there is any kind of recording of a person's residency status or homelessness status, in the places where that exists, they find that the average age of the person who is deceased is of this age. And so you can basically compare mean ages of people who have died by their status. And so that's sort of limited in sort of the intuitive ways, as far as like does it matter how long they were, what's the chain of causation that led them to be that? Did they become homeless did they become homeless because they were already ill, etc. This is sort of a long-standing issue, and there's some famous sort of reports trying to sort of untangle these kinds of things. There was a similar debate in the 1980s, including especially in England, actually, about sort of the when we look at the relationship between wealth and health, how much is basically poverty or lower socioeconomic status, or socioeconomic position, I believe is the term used. How much of that is due to a person's poor health, and how much of it is due to which way does the causation go? Does being in ill health make you poor, or does being poor make you in ill health? Something like that. I mean, to sort of jump to the next slide, the sort of the as you might imagine, it goes both ways. Housing insecurity or other sort of forms of poverty or deprivation cause illness, and illness causes housing insecurity. So homelessness and illness are in a reciprocal relationship, such that illness reduces one's ability to get income and housing. And then homelessness also creates a huge number of health outcomes due to exposure to dangerous environments, drug and alcohol use, which in some sense could be independent of homelessness, but also are very much in reaction to extremely difficult life conditions. There's sort of a plethora of information saying that self-medication essentially in response to dealing with extremely adverse life experience. And so what COVID-19 does is it adds an additional sort of causal effect at the population level, because the pandemic disrupted the whole social and economic structure of society, doing things like causing layoffs, loss of employment. Sorry, I'm not sure if layoff is a term that's used there. Reduced demand for certain services and so on. So the pandemic created new economic harms and hence new housing harms, even for the many people who are not ill. And so that's sort of adding an additional wrinkle to this relationship between illness and housing. Just to jump back for a moment. So looking at actually what was the direct relationship between COVID-19 risk and and homelessness, there's really quite a dearth of data in most places. In New York City, it seemed that people who are residents in homeless shelters in particular, so temporary shelters, had roughly 50% higher risk than other residents. Although that data is extremely noisy, it's kind of hard to tell what exactly to make of it. And more interestingly, I think, or sort of more broadly, sort of both, deaths among people experiencing homelessness, they spiked in U.S. cities. I think this was sort of the fear that was being responded to with the everyone in policy, with trying to get people off the streets in England, because I wasn't really sure what would happen to them. And so there was this massive spike in deaths. It's very unlikely that the vast majority of those deaths were actually due to COVID-19 itself, although there's sort of an open secret in the United States that our death certificates are a bit of a mess. And so they misrecord, or they misrecord information all the time, or they aren't especially concerned with whether a person died of exposure versus dying of COVID-19 or of heart disease, or some combination of different factors. And so in the United States, at the very least, we don't really know what people were dying of, but we know that they were dying in quite large numbers if they were experiencing homelessness. Much of that was probably due to disruption of all sorts of other services and lack of access to housing, lack of access to food options. It was just like basically any kind of large scale social disruption is always going to be most harmful to people who have the fewest resources. And so people experiencing homelessness are at the very bottom in terms of having access to resources. So they were going to basically feel the hit the hardest no matter what. And I'll be interested to see over time whether we can sort of figure out like what exactly they were dying of, for instance, because that does matter quite a bit. So jumping ahead and back and sort of leapfrogging over the slide I already jumped to, there are a lot of different exhortations inside the literature to sort of to think upstream. There's a lot of different language around this. One, I think, sort of helpful way that McMichael puts it, he's a public health scholar, is that we need to really resist, as we're sort of looking at any kind of problems like housing insecurity and COVID-19, or housing security and health in general, is we need to resist being what he calls prisoners of the proximate. And so it's very easy to sort of get stuck in the mode of only looking at the sort of like the local causal structure, and only looking at so what were people dying of? Were they dying of substance use disorders and overdoses while they were living on the streets during the pandemic, or were they dying of COVID-19 itself, for instance, or what were or in general, if we're looking at something again like that, that sort of like that observed sort of decrease of life expectancy, or is that which way is the causal arrow go, or something like that? And what McMichael says is, it doesn't matter what the proximate causes are, but you can't get stuck inside the proximate causes, because if you sort of are stuck only looking at the direct causes of death, you're always going to sort of be sort of effectively blinding yourself to all the other structural features that are upstream or at the wider social level. There are all sorts of different ways of conceptualizing this, to see how powerful sort of social forces, like everything like from climate change to gender roles and cultural norms about smoking and alcohol use and things like that, availability of alcohol, to availability of opioids, all these different things are sort of operating in the background. And so if we don't sort of scrutinize those, then we're going to miss a big piece of the picture. It doesn't mean we should only be looking at those kinds of upstream factors, but those upstream factors do matter quite a bit. And so accordingly, what I've argued in my work is that I think it's really helpful to try to think in a health system context, not a healthcare system context. This appears to be a bit easier for Brits, honestly, than it is for Americans. We are hyper focused in sort of like thinking only inside American hospitals, and when we think about health, and partially because we have basically a pretty threadbare social welfare system, and so we don't really think about anything other than what's happening inside hospitals when we think about health. But I just want to sort of point out that we have this very, very large set of social conditions like food networks and employment opportunities and workplace safety and economic policies, even taxation policies that are all sort of contributing to our health system. And so, so it's an agency or organization or policy need not have health in its name in order for it to be a a very powerful health factor. Which might not seem very, might seem sort of like relatively obvious to you, but it's a point I sort of find myself needing to make often, because it's very easy to sort of get caught up in exclusively factors that are sort of like just thinking about what kind of health policies are doing here, what exactly were people dying of at the moment of death, how is that being recorded, and we sort of need to be not prisoners of the proximate. So the kinds of relationships that are going on here is that there's this question about how does housing policy and homelessness and wealth and access and health outcomes, how exactly are those related, and what should we do about them, most importantly? I think it's really important just to point out that that looming over all of this, I think, is the relationship between wealth and health, and the factors that go into wealth in the first place. So, so in the United States, for instance, U.S. homeowners have just under 90 times more wealth than people who rent their homes. And so we're thinking about the relationship between housing insecurity or housing security and health. It's important to recognize that there's a separate relationship, or again, related relationship between housing and wealth itself. And so in the United States and in the UK as well, I believe in the UK that for the middle class, in the sense of the middle 60 percentile or middle 60% of the economic spectrum, that housing represents the largest sort of contributor, or the largest sort of portion of family wealth. And so basically like most net worth that families own is in some sense sort of tied up inside their housing. And so in the United States, we have an especially large, we have this huge gap between people who do have the benefit of owning a home. And so that's how they are able to accumulate much more wealth than people who don't have a home. And so so it's sort of complicating the picture that we have this relationship between wealth and health, and housing and health, and housing in some sense equals wealth. And so that's sort of complicating the picture here. And so in the United States, at least, more than half of that sort of wealth gap is due to homeownership itself. And the wealth inequities are extremely wide here. So going back to that question about, or going back to the point I was making about how homelessness as a demographic category sort of maps in some ways onto other demographic categories like race and ethnicity. And so there are massive wealth gaps in both the U.S. and Britain, such that we have white families and black families, or white British versus black African. These are not equivalent, but they're parallel, I think is a better way of understanding it. Is on the order of 8 to 10 times higher for it based on race or ethnicity. So this is a massive gap. It's interesting to note here, though, that this is median wealth gaps. The mean wealth gaps are actually even higher in the United States, because we have much more radical wealth inequality inside the United States. I know it sort of feels like you have quite a bit of wealth inequality in England, I'm pretty sure, but it could be worse. It could be American. So the proportion of wealth owned by the top 10%. So in Great Britain, it's just over half of net worth is owned by the top 10% in terms of wealth. Sorry, the richest 10% owns roughly half of your wealth. In the United States, it's just under 80%, and so we have quite massive gaps in the United States, especially between the haves and the have-nots. And so that maps on pretty directly the health wealth relationship in the United States, such that the privilege of having even something like a good income has a massive effect on one's life expectancy. And so in the United States, and it's relatively similar similar in the English context, although your curve is not so steep. Every single percentile that one goes up in one's income brings a corresponding increase in one's life expectancy. And so this is what the Whitehall study discovered essentially in the 70s through 80s, finding that this relationship between social and economic position and health is quite robust, and it sort of has this gradient feature. This is what Michael Marmot is writing about all the time since over the last 40 years or so. So in response to this sort of like, so when policymakers saw that there was this looming sort of the pandemic was arriving, there was already limited access to housing. Homelessness was a known problem in both of our contexts, in England and the United States. And so basically we each came up with analogous responses to it. And one of them was to say, well, what we can do is to try to set a temporary ban on evictions. And that's something that happened in both of our contexts at, I think, roughly at the same time, and with the same rationale, which is quite intuitive, which is that we don't want to sort of compound a pandemic crisis and a health crisis by creating a new crisis, which would itself be another crisis. And so if people start losing their homes, then we're going to have all those sort of health problems that are associated with homelessness, in addition to all the problems that are associated with COVID-19. And then we had reason to believe, and I think and we still do now, that there is an increased risk of COVID-19 by virtue of being homeless, because you aren't able to do social distancing, to maintain quarantines, things like that. And so there were efforts to try to sort of short circuit that sort of additional compounding of the housing insecurity and pandemic problems. But then there was immediate pushback against it. It was most sort of vocal inside the United States, where we our sort of private sector is a bit more sort of pushy than yours is, although it's not. It doesn't seem that yours is not. And so there was a lot of pushback saying that when the Centers for Disease Control put out an eviction moratorium, giving a very long sort of justification in terms of here's what will happen if we have people being evicted during a pandemic. It's going to make it impossible to track cases. It's going to make it very difficult it's going to make people's health outcomes worsen for a wide variety of reasons that we don't know the full extent of, but we know it's going to get bad. And so there was so the argument was made that there was a compelling state interest in trying to sort of short circuit this sort of negative outcome from the pandemic. But then there was immediate pushback as well, saying, well, that's an inappropriate use of state power, or this is what's going to happen to the landlords, what is going to happen to all of these, what is going to happen to the economic system by virtue of this attempt to try to save the social and economic fabric of society by preventing all these evictions. So this will be heading to the U.S. Supreme Court probably pretty shortly. Seems like you've had fewer legal challenges, although the sort of the fights over it and the aftermath will certainly be important there too. I'll come back to the aftermath shortly. So what this gets at is really a long-standing philosophical fight. There are actually a few different fights at stake here. So the pushback, especially that it was inappropriate to sort of for something like the Centers for Disease Control, which does not normally have any sort of any role in setting housing policy, stepping in and playing a role in saying, well, we are going to unilaterally ban all evictions of tenants of housing during the course of the pandemic. So there was pushback that was in the United States. It was, to be perfectly frank, it was largely motivated by objections that were objections to policies that would benefit the poor at the cost of the rich. In the United States, our landlords tend to be more corporate, and our individuals who are landlords tend to be richer than they are in the UK. And so this was in some sense sort of like not a wealth redistribution scheme, but it was a sort of higher cost for the wealthy and a higher benefit for the less wealthy. But motivations aside, there is something here, and so the debate I think sort of nicely sort of coalesced in a fight between Mark Rothstein and Daniel Goldberg, where they had this fight over what is the nature of public health work and where's the scope of proper public health practice. And Rothstein makes a pretty strong claim that the resolution of underlying socioeconomic and political problems is beyond the domain of public health. So he's again going back to that sort of dichotomy of the sort of normative and descriptive, or that sort of coupling, as I use Nancy Tawana's term quite a bit. He's saying this in some sense both descriptively and normatively, and so it is literally beyond the scope of what people in public health are trained to do. It's what's, I think that's factually a false statement, but it's a factual statement. It's beyond the scope of what's the sort of the scope of theoretical application. It is beyond the scope of what associated agencies are empowered to do, and it's also beyond the scope of what any of these agencies or practices or professions ought to be doing in the first place. And so the CDC and public health ought not be setting housing policy, for instance. I mean, he's making this claim in 2009, so this is before the pandemic. But it is sort of beyond the scope of what they are doing, should be doing entirely. It is, so this kind of thing is just not a public health matter. And in a reply, you have Goldberg saying, well, I understand your fears. So I concur with Rothstein's fears in adopting a broad model of public health. So if we say that something like housing policy is public health policy, and there needs to be some sort of relationship between the Centers for Disease Control or the NHS or whatever and housing, that he says, oh, I see no policy alternative, because I maintain, and this is a factual statement, that social conditions are primary, if not exclusive, causal factors in public health. So as a result of that factual claim, which I think is pretty well backed up, expressly adopting a policy approach that is designed to avoid addressing such social conditions is untenable to me. And so this is sort of why I'm interested in this interplay between the normative and the descriptive in public health, because this is making this claim that that because of the sort of the descriptive nature about what we know about causation of health, and that relationship between health and wealth, and housing and health, and housing and wealth, because of those kinds of relationships, that we're sort of forced into the position of either sort of being ineffectual, and because if we're not going to ever address housing directly, then we're going to be pretty limited in our ability to actually promote public health. And so we have to either accept that we're going to be of limited ability to intervene in the world, or we're going to have to sort of bite the bullet and say, oh, okay, we're going to do this kind of thing, but we're going to be risking a lot of normative missteps here. But that's sort of the choice, is either you sort of accept this sort of small public health, and you become ineffectual, or you accept this big public health and become effectual but dangerous, or something like that. So I elaborate on this point in my book and in chapter 4, my past book. So obviously not outside the context of the pandemic, because it came out in 2018. But one of the points that I make is that in my sort of defense of this broad model of public health is, I think one of the worries is that if we say that housing is a public health problem, or that the Centers for Disease Control or the NHS or whatever other kinds of health agencies ought to be involved in housing policy, that doesn't mean that they ought to be the only ones. And so just because a problem is a public health problem, so in the United States, for instance, there's a big fight over whether gun violence is more of a criminal justice problem or a public health problem. There are very different approaches that one would bring to bear on that, or on substance use disorders. Is that a matter for criminal justice, or for the health system, or for other sort of for social workers and other sort of social welfare agencies? Like, who ought to be sort of playing a role in this? And I think it's just a conceptual mistake to say that it's only one thing. And so gun violence can be a criminal justice problem, and it can also be a public health problem. They are not mutually exclusive. It does not mean that the Centers for Disease Control is the only one setting housing policy, but it does say that they have a legitimate role in it. So I can elaborate on that point during Q&A later, but I was making that point in the context of what Goldberg and I both advocate for is explicitly a population health approach. And so there are some features of that population health approach that I think are relevant here, because it gives a little bit of context to this, to why it's important to sort of think about housing and housing security broadly when we're thinking about how to sort of build a healthier society in the wake of the pandemic. And so a population health approach has been described in various ways. Keyes and Galea are two of sort of the prominent defenders of it. And they call it a research program that confronts the structural forces that places individuals at risk, creates distributions of disease and of health and disease unequally across socially defined groups. So again, these have these sort of socially defined demographic categories, and so there are forces that make it such that they have different experiences. So people experiencing homelessness, people with different ethnicities or races. So it's sort of being so you can sort of notice that inside the language here is there are forces that create these inequities, and it doesn't matter exactly which ones, if we're to just identify them as being inequities in the first place. That's just sort of a little side note going back to what I was saying before. So it creates distributions of health and disease unequally across socially defined groups, and it focuses on embedding biological pathways. So there are these known biological pathways like infection and death, things like that, embedding those within social interactions that develop across the life course and across generations. And so what are the upstream factors? What are the longitudinal health factors, such that someone might be facing adverse childhood experiences because they grew up in poverty? That might, in reaction to that, they might start using excessively using alcohol or drugs, and that could lead to homelessness, and that in turn can lead to higher risk of COVID-19 infection or whatever. So each of the sort of local proximate relationships matter, but it's important to sort of embed those within a bigger picture. And so this is a way of thinking about a bigger picture. The model that sort of developed around this field is this catchphrase of a culture of health, and that we need to build a culture of health. And what's basically being claimed there is that we need to have the entirety of cultures to be health conducive, or that if we have a lack in an area of a culture, broadly speaking, then it's going to manifest in worse health outcomes. And so it's not just that we need to have better housing, or just that we need to have better food systems, or better urban design, or better whatever, that we sort of need all the different aspects to sort of align in ways that are actually going to be health conducive. There's not a single way that's going to play out, but that we need to have cultures, plural, of health inside individual communities. Or at least that's sort of the preferred sort of terminology. I can sort of elaborate on that. And I think this is roughly sort of the right approach, or at least the sort of right sort of like mindset. And I think it's interesting to see like where it's coming from. I sort of see this exhortation that we need a culture of health as basically being sort of like a reaction. It's not the only reaction, but a reaction to this sense of awe at the power of social context. So once you see the scope of health disparities and wealth disparities, or when in the United States we have sort of the privilege of having extremely fine-grained data on health outcomes just by geography, and so I only found out a few years ago that the neighborhood I grew up in was at the very borderline between two different sort of like a chasm in terms of health outcomes, where I was on one side of a road, and on the other side of the road, people died roughly 11 years younger than people on my side of the road. And so that is not actually all that uncommon inside the United States. And so I knew that there was sort of like a neighborhood change if I sort of went 2 blocks away, but I couldn't just sort of look there and see like, oh yeah, people are going to die over a decade younger by virtue of living in a sort of a different neighborhood. And so once you sort of see the scope of some of these problems, then I think it can inspire. It doesn't have to, a certain sense of awe. And the way that Jeffrey Rose responded to this, he's sort of like one of the theorists who, so he worked with Michael Marmot on the Whitehall studies, and he eventually became sort of like the champion of or sort of one of the developers of population health thinking. And he eventually made this point that he started his book this way right before he died. He said, "There's no known biological reason." So here's a factual claim why every population should not be as healthy as the best. And so individuals will vary in their health. And so you know, in my neighborhood where I grew up, some people are going to have a family history of heart disease and some aren't. Some people are going to get cancer and some of them aren't. So there's quite a bit of sort of noise at the individual level. But there's no reason why in my neighborhood or why my block, like the group of a few hundred houses that was being measured, why that one should be radically different from the one next to it. And so there's no reason why the neighborhood next door would have to die younger than mine. So there's and so he was making this sort of biological claim that there's no reason why this must be the case. But I think he's sort of making this descriptive case as sort of like a normative provocation. And so he's saying that there's no reason why, based on sort of the structure of biology and medicine, that this disparity must exist. And so that sort of pushes back on us the policy challenge of, so what are we doing wrong such that it is happening anyways? What are we doing wrong such that there are people dying so young while they're rough sleepers in England? Why are people in the town of Brighton, which was next to my town of Newton in Massachusetts, why are they going to be dying 10 years younger than or 10 and a half, I believe, years younger than people on the other side of this street? And so that's sort of the challenge that's being put forward, is saying that it need not be this way based on what we know about the structure of biology and medicine. And so if it need not be that way, then what are we going to do? How are we going to build this culture of health? That sort of term came after him. How are we going to build a culture of health such that it doesn't happen that way? And so the idea that was put forward eventually was that, or the idea that's sort of been developing over time, so before, during, and after the time that Rose was working, was this idea that we need action across the whole of society if we're going to have effective health promoting policies. And so it's going to take all these different sort of pieces aligning in certain ways. And so one of the first moves was in 1988, the WHO had the Adelaide report, saying that we need that trade unions, commerce and industry, academic associations, and religious leaders have many opportunities to act in the health interests of the whole community. And so new alliances must be forged in order to provide the impetus for health action. This is sort of getting the ball rolling and thinking about how we need sort of different sectors of society involved. I can elaborate on this too. This eventually turned into, inside the European context, this turned into a sort of a more formalized approach called the health and all policies approach. And the way it's described in this original sort of document, sort of laying out the approach, is that it seeks to improve health and at the same time contribute to the well-being and the wealth of nations through structures, mechanisms, and actions planned and managed mainly by sectors other than health. And so it's not only saying that it requires more than an effective healthcare system, you know, a well-functioning NHS, for instance, but actually that the way we can sort of that trying to promote good health is actually going to be primarily action that's done outside of the healthcare sector in particular, which is a rather strong claim. And eventually this got adopted by various sort of nonprofits and professional societies, things like that. So for instance, the American Public Health Association is the largest public health nonprofit in the largest public health professional society in the world. And they say that population health and equity depend on collaborative intersectoral action. We need this sort of action across society if we're going to actually have an effective health promoting world. Eventually, Kickbush and Gleicher put in the WHO Regional Europe report. So again, a lot of the work on this is being sort of done in the European context. That we need approaches to health that not only engage with the whole of government, but we need to engage the whole of society. This is something that really came up during the pandemic. You can make whatever policies you like at the national or national, city, whatever level, but if people are not going to actually participate in them and endorse them, and to really be committed to them, then you're going to they're going to be ineffectual, or at least not as effectual. So, in the United States, for us, that sort of big fight was things like masks and social distancing. And so you can tell people they have to wear a mask, but if they just don't do it, then that policy is not going to be especially effective. And the reasons why they don't do it is going to be for really quite complicated cultural reasons. In the United States, we had the politicization was a little bit different than it was in the UK context, in terms of like the aligning of the politics of like who participates in certain kinds of pandemic mitigation things and why, and all things like that. So it's this is sort of pushing on this idea that we need this sort of culture of health. Otherwise, we're going to not have nice things. So right now, the tide is sort of turning on the place of housing in society. This is happening in Europe. It's happening in the United States. It's happening elsewhere as well. There's more and more recognition of housing as more than a privilege for those who happen to be able to afford it, and that's a good thing. There's been sort of growing efforts to recognize housing as a human right in and of itself, which is sort of like one of those interesting points that's sort of like on the line between like so radically minimal or something like that it seems like it doesn't even bear mentioning, or it's so radically progressive that it doesn't even seem reasonable to even assert such a thing. Because if you recognize housing as a human right, then what does that mean about our obligations to people who are experiencing homelessness, or about how we would structure our housing policies to say that everyone has the right to this the same way they have a right to have access to a criminal justice system, or to have protection by the military, or something like that. And so it would be like both radical and minimal, or something like that. Sort of depends on who you ask. So to give a quick contrast between, and so one of the things that sort of emerged out of this was this idea of trying to create homelessness policies to combat the problem of homelessness that use what's called a housing first model, which maybe some of you have heard of, but I'll sort of elaborate on it. So to give a comparison, the United States is especially bad in this way, although there are similar sort of bureaucratic complexities in your context as well, just not nearly as bad. So in order to get housing assistance, so if you are experiencing homelessness, or you're about to experience homelessness, there's quite a gauntlet that one has to go through in the United States in order to actually get housing support. It's through a national program called Section 8. And so, first of all, you have to be U.S. citizen or permanent resident. There are some analogous limitations on such social welfare services if you are in England. If you have settled status, for instance. I know that you probably know more about how this works than I do. In the United States, you have to earn less than 80% of the median income for the region, which is a bit arbitrary, where it's basically setting the standard for poverty based on how much money people make in a certain area. So if an area happens to be impoverished in general, that means that you have to be poor among the poor, for instance, in order to be eligible for housing. And there's only priority given for people who earn less than 30% of the median income for the region, which is extremely low bar. And so just to choose like sort of like a random place, I was talking to people in Indiana recently, so just to give a sense about what exactly that would mean. $16,000, so just a very, very low income. That's not even in the ballpark of living of what it takes to survive inside the United States. You can't have any recent history of evictions due to drug use. So if you can't have been thrown out of housing because of drug use, and so if you have, then you are quite out of luck in the United States. You can't have any criminal record that's deemed relevant, which is a individual call that leaves open a lot of possibility for discrimination. And you still have to meet credit check standards that are set by landlords. And so you cannot have bad credit in the United States and still get emergency housing, which is a bit of a ridiculous thing, because if you are experiencing homelessness, then you probably don't have great credit because you owe money to lots of people and you haven't been able to pay back on time and that sort of thing. So, and you still have to pay, even if you get get lucky enough to actually get housing under this program, you still have to pay 30% of your gross income on the housing. And by contrast, the model that the world is sort of watching very carefully is the Finnish model, where the housing assistance eligibility is, if you don't have a home, then you shall get a home. This is, which is relatively straightforward. And so, so this is called the housing first model, where basically it sort of short circuits this these sort of means tests or whatever, so that, you know, are you endangered enough to deserve shelter? If you deserve shelter, shall we provide you with transitional housing, temporary housing until you get on your feet or something like that? Something that's designed to be short term and limited in quality, limited in scope, or whatever. This provides all sorts of disruptions to things like mental health services. This has been a continuing problem across much of the world, where if a person is experiencing homelessness, it's very hard to provide them with consistent care because we don't know where they are. So the housing first model says that you just go immediately from experiencing homelessness to getting a permanent home of some kind. It need not be your permanent home for forever, but it is not time bound in any sort of predetermined way, that you deserve housing and you shall get housing for as long as you need it immediately, as opposed to having to sort of jump through all these sort of hoops like in the United States. And that provides better access to things like mental health care and medical care and behavioral health care, things like that, and overall stability. So there's a lot of interesting research now. There was some large scale studies happening inside England, actually. I believe it was in the north of England, looking at the effects of housing first. But I believe I just read that they ran out of money for doing some of the implementations, and so some of the experiments were actually just fizzled out because there was insufficient funding to carry them on, which is rather depressing too. So there are all sorts of efforts to find out, like, what do they do to long-term homelessness, to health outcomes, to mental health care. In the United States, there's a lot of interest in arrest and incarceration. So just this sort of reduce criminal justice involvement. Does it overall cost less to society by sort of like macro level economic measures? And it seems to be in general that housing first policies, when implemented at sort of these micro scales, that they cost less to society overall than sort of existing homelessness policies, or they might cost a tiny bit more, but by every measure, the outcomes tend to be better. As you can sort of imagine, that people prefer to have permanent housing as opposed to temporary housing, that they have more life stability, that they have more income if they're not spending, for instance, 30% of their income on their housing if they are impoverished. So there's sort of little doubt that people who are sort of beneficiaries of these kinds of programs do better, but but the sort of overall cost to society is a bit sort of up in the air. It's quite possible it actually costs society less by sort of like whatever sort of general measures you might use. And so what this is all sort of like combining to bring forward is a question about, like, how do we want to have housing policy and housing assurances fit into a culture of health, if we indeed want a culture of health, or cultures, again, we can pluralize this. And so one thing that's really taken a sort of like really disastrous sort of like sort of looming effect over both of our contexts is, in England and the United States, we have this very, very scary problem of rent arrears. And so when we had eviction bans in the United States and in England, and those are all sort of coming toward an end now, what happens to all that money that people owe? And so in both places, it's not as if people's rents were forgiven. You were just not allowed to throw somebody out of their home. But if you still owe thousands of pounds or thousands of dollars to your landlord, the moment that those eviction bans go away, then landlords will be free to throw people on the streets because we've decided there's no longer a problem. This has been pointed to as a problem as like sort of like a looming problem for many months. So this is not now people just sort of realized that this was going to be an issue. But in both of our contexts, it seems that policymakers and landlords and individual renters are just totally unprepared for what's going to happen next. There is no solution that anyone seems to be really putting forward that's going to actually deal with this problem directly. And so as soon as evictions are allowed again, then it seems like a lot of people are going to be in deep, deep trouble. And so what we could have had was things like rent being directly paid. So instead of having eviction bans, we could have actually paid people's rent at the national level, at the state level, at the local level, whatever it might be. Instead, we have a delayed eviction while rent arrears were continuing to grow and grow and grow, as they're still doing now. We could have had a housing first model implemented during the pandemic, or we can implement one now. In the U.S., again, that sort of Section 8 policy is just like a gauntlet of ridiculous bureaucracy, and it's extremely slow. It seems like you're making great progress in England with the universal credit system, basically trying to replace a lot of the social welfare services with a sort of unified single payment in order to provide people with enough supplemental income in order to do things like pay their rent and pay for food and things like that. The problem seems to be that number or that amount that people are given is not keeping up with the actual costs of living in England. And so if you're not getting enough money to actually afford your rent, then it's great to have some money, but then if it's not enough to pay your rent, then what are you going to do? You're still going to have the problem with housing insecurity and food insecurity and so on. And so a nice step in terms of approach, but if you're not keeping up with if the numbers just aren't adding up, then it's no less disappointing in a lot of ways. We could have, in the US, we could have done something like the Everyone In program, and we failed to do that. And I sort of applaud England for actually doing something like Everyone In, for making sure everyone had basically pandemic safe housing, or trying to make sure everyone had pandemic safe housing during sort of these stay-at-home orders. In the United States, we actually did sort of the opposite. There were sort of accelerating efforts to tear down any encampments where people were basically sleeping rough. So there would be like areas under bridges and inside abandoned golf courses and things like that, where people still would set up ad hoc camps to live with other people experiencing homelessness. And there were rather brutal attempts to basically tear those down. So they would bulldoze them to the ground. For instance, in my city, in Los Angeles, there was an especially large one that was done. Even though that was contrary to CDC advice, saying that if you do that, then people are going to it's only going to get worse, not better. And it appears to have. So it's really good that you did that in England, but it's also unclear how well that you're sort of sticking the landing, so to speak, in terms of there were attempts to try to get people into more permanent housing as the Everyone In scheme sort of started coming to an end. But then it's very unclear based on the existing data what actually has happened to people. So have they found permanent housing, or just like another round of temporary housing? Because again, like that's just going to sort of put people back into the problem of not having long-term housing, and it's going to continue being a problem because if you don't, even if people do get more long-term housing, if they still don't have enough income to actually pay their rent and actually pay for other needed expenses, then it's just going to be sort of like a ticking time bomb, in the sense of like, well, you have housing now, but if you still can't afford to live, just more broadly, then that's going to be a problem. And then we really could sort of push harder on this thing to recognize housing as a human right. And that's not to say that the human rights framework in a philosophical sense is sort of like the best one. I think it's sort of limited and it's sort of it's a limited framework that I'm not sort of particularly committed to in terms of human rights versus other ways of conceptualizing like human obligations to protect each other, that sort of thing. But as a political guarantee or something like that, I think that's something that we could push for now. Now, I would sort of be really happy if we actually made some headway on that with the sort of pandemic housing crises, and then the sort of affordability crises that are impacting both of our contexts. If we don't sort of push on that now, I think it's going to lead to more housing policies and more housing sort of efforts. They're designed around trying to provide people with more luxury apartment complexes and flats, blocks of flats or whatever, as opposed to having affordable housing for everybody or something like that. So anyway, I think I will stop there and just I want to sort of give a nod to Noddings that I think she makes a good point that there is a certain ineffable feature here, that it's not just that homes are sort of necessary for protecting one from the elements. For instance, there is sort of a deeper sense about it. It can be fundamental to one's identity, and so your home is your home. This is also this sort of related to the rationale for housing first, and so that the ineffableness about having a permanent home as opposed to a temporary shelter is sort of hard to capture, but it matters, even if it matters for sort of practical reasons, but it also seems to matter for sort of like deeper reasons that are hard to sort of put your finger on. And I think nodding sort of makes a good point that that a home is an extension of ourselves, and so we shouldn't sort of underestimate in a sort of deeper philosophical sense the importance of a home. So I think I will stop there, and thank you for bearing with me.